me to help with his shoulder. So Jonathan, if you want to come through, thanks. Thank you. Thanks, Justin. Nice to see you again.
Nice to see you too.
So I'm going to go through how I would treat, and Jonathan's been prepped on what I'm going to do today, so he knows that obviously this is a bit different to a normal assessment. So, but hopefully this will give you an insight on how we treat shoulders in Australia. So, Jonathan, what brings you in today?
I got some shoulder pain, a little bit somewhere around here, and goes down. Doesn't go below the elbow, sort of in that area.
So nothing down into your arm?
No.
Nothing down into your hand?
No.
Any pins and needles or numbness?
No.
Okay. Anywhere else you get pain?
Yeah.
Other than here?
Sometimes it sort of goes up a little bit into the neck in this area.
Okay.
Yeah.
Sometimes?
Yeah.
When is that sometimes?
So I noticed there is some relation with this one too. When I'm sore here, it's sort of sore there as well,
Okay.
or the other way around. So it's been there since about 6 weeks or something.
Both of them have been with you for 6 weeks?
Yeah.
Okay. Any problems at the back?
No.
Okay. Any problems on the other shoulder or the other side?
No.
Nothing. Okay. That's good to know. Any past history of back problems?
No.
Now, the reason I asked about Jonathan's back is we know from studies, and we know from anecdotal research as well as studies that low back problems predispose people to shoulder problems. So if Jonathan had a past history of back problems, I would then investigate that a bit further, and certainly would be in my plan to assess at a later date, even related directly to his shoulder. So we have with Jonathan primarily very localised shoulder pain, lateral, some radiation, well, some other pain up into the upper trapezius region, which he feels is related both historically, it came on the same time, but also we know that one leads to the other. There's a behavioural link, which tells me that I really will need to look at his neck as well today. If he had this neck problem before, and it hadn't changed with his shoulder, it still might be relevant, but it may be something I'll push back later in assessment. The fact that this pain and this pain, which are two different areas in his world, yet they have a behavioural and historical link, tell me that I need to look at that on day one. No neurological symptoms, which is good. I'm just going to ask some red flag questions just to write out everything else. No problems feeling dizzy, nauseous, no problems with shooting pains down your arms or your legs.
No.
Any change in your weight recently?
No.
Okay, good.
Stable.
Good and stable. Okay, beautiful. So look, just doing some screening questions to make sure there's no other nasties that could happen with his shoulder. Feeling unwell or feeling other than the pain? Yeah.
No.
Okay,
Pretty
good. Okay, and I would not need to do a neurological examination as he's got no paresthesia or anaesthesia in his arm or a description of weakness. So I'm just going to go now to the problem. So Jonathan, you said you've had it for 6 weeks?
Yeah.
Okay. Can you tell me, can you remember, was there a moment where it started, or can you explain to me how do you think this started?
Yeah, I actually started painting my house.
Okay.
So
You're a painter?
No, I'm an accountant by profession, but I'm not used to painting a lot, and so I started painting. I thought I'd give it a shot, and I had to keep my arm up to overhead at times as well for quite a while, and that's when I figured I started developing it, and that's when the neck started getting a bit sore as well.
Okay.
Now, it used to be sore earlier as well, the neck a little bit, not as bad as it is now during working on the computer and stuff like that.
So when you say that earlier, you're saying you've had this problem before?
No, not the shoulder problem, but
Okay.
neck was a little bit achy before.
So you've had this sort of pain before, but not this before?
No.
Okay, so what do you said you've had that before,
Yeah.
but that's got worse still, despite, since
Yeah.
this has got worse. Okay.
Yeah.
So how long have you had this problem for? The problem, you said it's got worse, but you've had it further back, you're saying?
Yeah, probably 12 weeks since now.
Okay.
Yeah. So
And again, do you think, was that painting as well? What do you think? You mentioned something about your work. Or your
yeah. So being an accountant, I spent a lot of time in front of the computer. So working there, I used to notice by the end of the day, I'd get sort of achy there in the neck area. And since then, after the painting bit, now the whole thing is pretty bad.
Okay. So even more important, I need to look at the neck on day one. Many shoulder problems have a coexisting neck problem, but given that Jatin already had pre-existing neck pain for quite a period before the onset of his shoulder, tells me that I really need to look at his neck as well, vitally on day one. Obviously the trigger is different. It sounds like it might be related to his work. I'm finding this year, because a lot of people are working from home, and we'll find that out from Jatin, rather than their desk. They're working from home and their workstation's not so well set up. They're also using a lot of home equipment like laptops, which aren't as well designed as a workplace at their workstation setup. So I'd be interested to hear from Jatin on that. Jatin, you said it started about 12 weeks ago, this little bit. Has that, I know you said you've been doing work as an accountant, but any different? Well, what made you suddenly get sore, because you've been an accountant for many years?
Yes, now that we talk about it, that's around about the same time I started working from home a bit more than, working from home wasn't as much as a thing before the COVID situation. Yeah. So now, I've been spending more time on the laptop, and my desk isn't as ergonomically designed at home than it is at work.
And that's common, which tells me part of my management would be to look at Jatin's workplace at home, if he's staying at home. So maybe what I usually get people to do is to get a photo, get their partner to take a photo of them at home to show me their workstation set up, and whether we need to adjust some of that, do some ergonomic changes, because that certainly would predispose his neck. On top of that, we know, again, like I talked about backs, that if somebody's got a problem with their shoulder and a problem with their neck, that neck pain can leave you predisposed to shoulder problems. There are many studies. One really well-known study shows that deep neck flexor endurance, which is commonly an issue that predisposes you to neck pain, is also an issue with shoulder problems. And what will happen is if you retrain the deep neck flexors, you get immediate improvement in shoulder function. Now, they don't know if it's, we call it in English, the chicken or the egg. We don't know if the pain in the shoulder leads to inhibition of the deep neck flexors, or because you've got problem with the deep neck flexors, it predisposes you to shoulder problems. We haven't got the research yet to know the answer to that. However, what we do know is if we retrain the deep neck flexors, we can improve shoulder strength very quickly and shoulder function. So irrespective of which so Jatin, we've got a clear history. Has it changed in the 6 weeks?
It's actually been getting worse.
In what way?
The pain intensity has increased, and it's never been this sore in the past.
Okay, so it's getting more and more severe. Okay, have you done anything in the 6 weeks? Have you done anything for it?
I tried some heat.
Yeah.
I noticed like if I use a wheat bag, it relaxes the symptoms for a bit,
but just temporary.
Yeah.
Okay. And anything else you tried?
No.
Haven't taken any tablets?
No, not yet.
Okay. Seen your doctor?
No.
No. What led you to come now then? So you've had it for 6 weeks. There's usually a reason somebody makes a decision to come and see us.
I thought initially it'll just get better, like maybe after a while, but notice it's been getting worse and worse, and then finally I just thought, now it's past that stage, I should have it looked at by a physio.
Good. And you said it's getting worse too.
Yeah.
So on that, what are you having troubles doing? What are you said it's getting worse, so what sort of things are you having troubles doing?
The worst is lifting my arm up above, say, just if I go above there, I can really feel it in there.
Okay. Can you give me some examples? What sort of activity? Like taking off your shirt?
So a little bit while taking off the shirt, yes, it's sore, so getting cups or dishes off of the fence, off of the cupboard. That would be the main, and I can't paint anymore. Like,
so you've had to stop painting.
yeah,
You need to finish.
I need to finish. It's half done.
Can you take your top off normally, or do you actually have to do the old with one arm?
Yeah. So I have to find a way of getting it out. Yeah.
So the reason I want to find this out is I want to find out his functional limitations, because then I will match my treatment to his functional limitations, which is a critical part of great care of physio. The other thing I do is I can understand what he has to go back to, and I can help set goals, and they become key reassessment points. So my goal is to get Jatin. The first step would be to be able to take off his shirt normally. Second step would be later to get him back to painting. So I know that's going to be a hard work because there's a lot of repetition there, there's a lot of load. I may need to look at ergonomics with that, and I will find out later, maybe not today, but I would want to find out if he's using just a normal paintbrush and a ladder, or if he's using a long extension one, because sometimes just changing ergonomics is critical. One thing that's critical for all shoulder management is you want them to be doing any functional activities below 90 degrees. So it's critical if you've got somebody who's doing painting, as Jatin has said, that he shouldn't be going above 90 degrees of flexion. If he is, you must give a pole. They need a pole to actually reduce the load, because once you get over 90 degrees, the load on the cuff is significantly more. Coming back, Jatin, any difficulty, what do you do when it's bad? I know you said heat, is that really?
Yeah, so I cease the activity. So, that helped. And now when I think about it, I did have some Panadol as well, and that kind of helped me.
Okay.
So
Well, look, Panadol doesn't have much research, but for shoulder pain, but it's actually quite safe. So in your case, if it's helping you, keep going with it. And again, this comes back to evidence base. The evidence for paracetamol, which is what we call, Panadol's a brand name, but I'm sure in India it's paracetamol. The evidence for shoulder pain and the use of paracetamol is poor. However, that's population-based research. For individuals like Jatin, he said it helped him, so I would never discourage him, particularly when it's a relatively safe medication like paracetamol. If he's getting some relief with it, I'd encourage him to do that, to keep with that. Any trouble with your sleep at all at the moment?
No.
So you can lie on that side?
Yeah.
Okay, good. Well, that's good. Is there any time of the day it's better or worse?
Now, as the day progresses with activity, I feel if I'm using the arm a bit more, it's a bit worse.
Okay. So that tells me that the tendons, we're assuming it's a tendon at the moment. That's a reasonable assumption, by the way. The research says 2 out of 3 patients who come in with atraumatic shoulder pain, just like Jatin has atraumatic shoulder pain, 2 out of 3 will be a rotator cuff problem. Now, when I say rotator cuff problem, that includes tendinopathy, a atraumatic tear, subacromial bursitis, subacromial impingement. They're all put into the same label, rotator cuff dysfunction. And Jatin certainly is a 2 out of 3 chance that Jatin has that, because that's what the research says. So far, everything's telling me that it probably is that. There certainly wasn't a sign of trauma. So even though Jatin's quite young, atraumatic tendinopathies aren't uncommon when you're not used to doing activities like Jatin. An accountant is probably not doing painting very often in their house. No night pain, so it's a very, thankfully, not a very inflamed shoulder. Often when you get bursal involvement with subacromial bursitis, which again is part of that whole circle of rotator cuff related problems, it can be quite inflammatory, and obviously reducing that becomes part of your management. But given he's not getting night pain, he hasn't got morning stiffness, then there's no need for him to take anti-inflammatories, non-steroidals. There's no need for me to give him much caution. It doesn't sound very irritable. Once he stops, once you've stopped doing your activity, it doesn't.
No.
So he's not irritable. So we've got a fairly clear picture with him. And what are you looking for from today's session, Jatin?
I'd like to understand why it's happening or what it is, and some pain relief.
Okay.
Nice.
And that's okay. Hopefully we can help deliver that. And the best I can tell you from experience and from the research this is one area where exercise therapy can give you immediate hypoalgesia. So I'm going to be looking, and this is a lot of the current approaches, Jeremy Lewis, Chris Littlewood, a lot of the contemporary approaches are about giving immediate pain relief. So you can actually start working on deloading the tendon and then gradually building up the tendon load. It is one of the best approaches, certainly for getting patient engagement too, because if you can give immediate hypoalgesia, the person will be much more compliant with exercises. So my goal is for Jatin to leave with 1, maybe 2 exercises only. You want to keep the number of exercises to low numbers. Low numbers of exercises greatly increase compliance. So I'm going to try and give Jatin a treatment plan that involves maybe 1 only, perhaps 2 exercises that he can go home with. And he will see in the rooms, I hope, Jatin, immediate pain relief. That's the goal. If it is rotator cuff, we should be able to give you pain relief like that. Does that sound good if we can? Yeah. And then hopefully, you can imagine if it feels good in here, imagine what it would feel like if you do those exercises every day.
Yeah.
So one of the keys with really good clinicians is you share knowledge with your patients and you get them to think about your answers. So if you notice what I said there, what I said was, I want you to imagine if we can give you pain relief in the room, so if you can replicate that with home exercises, what would that do to you? And usually you get much more buy-in than just saying, do these exercises. So really important, share with them improvements. If I can get improvement within the room, I want to give them that as a home exercise. And you can imagine if somebody gets improvement in the room, how powerful that is to encourage the person to do the same exercises at home. So here's some steps. Now Jatin, I've asked Jatin if he doesn't mind being my cameraman in between. So Jatin, do you mind coming over? Thanks. So here we are. I'm just going to write down some key points. So we've got a 2 out of 3 chance of it being a rotator cuff. Even if you don't know what it is, you've got a 2 out of 3 chance it's a rotator cuff if it's an atraumatic incident. The differential diagnoses for lateral shoulder pain, which is very common, which is atraumatic in nature, you obviously want to make sure you don't miss frozen shoulder, and there is a chance it could be an instability. Now, in Jatin's age, how old are you again, Jatin?
32.
32. Frozen shoulders are fairly uncommon, unless he's got comorbidities such as diabetes, which I didn't ask your health. Sorry, asking behind the screen, your health is good?
Yeah.
Yeah. I did know that before because I've treated Jatin before. He's got no other medical history. But key features of frozen shoulder is loss of external rotation passively and actively, greater than internal rotation and flexion, but they are all lost, but the range is usually half of the opposite side. So usually it's less than 30 degrees. So somebody comes in and you do straight external rotation and neutral. If they can only get to 20 degrees and the other arm can get to 40, 45, that should alert you that it may be a frozen shoulder. So that is what I will do with Jatin in a moment when we finish this bit of the video, but that is one thing I'll be looking at. It'll be a very quick test. I'm excluding that. If it is frozen shoulder, it's a very different approach. Not time to be able to discuss that today. The more common one in Jatin's age is an instability. Now, instabilities don't occur spontaneously. Wouldn't be from painting. You would have had to have a trauma. Now, I can be pretty sure that he hasn't. Again, I'm just asking you, Jatin, no, your shoulder hasn't felt unstable or wobbly?
No.
But I wouldn't even ask that with the history that Jatin gave. But if he gave a history of playing a sport, particularly an overhead sport where his arm was not, like going for a catch in the outfield in cricket and he landed on a hand like this, then that would raise dramatically some other pathologies, particularly instabilities or ligamentous tears. Given his history, I can pretty much exclude that as well. What we can't exclude is the cervical spine. So what I'm going to be doing is a very different approach to the normal observations, active movement, passive movements, resisted statics, palpation, maybe pavins. That is the standard sort of physiotherapy approach, certainly in Australia. But for time and to get the best results, I want to go for a more systematic approach. We know many shoulder problems have a cervical component. Jatin's already mentioned he's getting pain through here, and he had it already there. So that's going to tell me that's going to be really early on. I need to check that. And then I'm going to do some isometric testing of the cuff. Now, isometric testing, we know from the studies by both Jeremy Lewis and Chris Littlewood that the most common one to be involved is abduction. In fact, about 70% of your patients will find the abduction is the most provocative, but interestingly, the one that if you rehabilitate that will give them the most improvement. About 25% will be external rotation, and about 5% will be flexion, and the occasion can be internal rotation. But here's the key thing, is you relate it to function. So relate to function in your testing, and I'll go through that with Jatin in a moment. So for Jatin said he had problems putting on his shirt with reaching. So I'm going to get him to do a reaching manoeuvre in a moment, and I'm going to use that as my reassessment to see if the neck's involved, and if isometrics, that is if cuff loading is involved as well. And also with Jatin, if I had time on day one, because he's got neck involvement as well, I'd also do an upper limb tension test, neurodynamic testing. Anybody with upper quadrant symptoms, be it neck, shoulder, but particularly when they have both, it is really important you don't forget the upper limb tension test, because in many shoulder patients it's involved. Now, it may be negative, and obviously you have to respect that when you go out into abduction, the standard test may be already provocative. And if it is, start them a bit lower down. Start them short of P1 with abduction, record that, but then do your upper limb tension test in a limited abduction. Do some palpation. Now, it may be you don't do palpation, you may not do soft tissue work on day one. It can be useful. The research is good for manual therapy for acute shoulders, which Jatin's still in. For shoulder problems, we know that adding manual therapy into your rehabilitation with your cuff rehabilitation, starting with isometrics if it's effective, greatly enhances a faster outcome. So I've already got in my mind, I'm probably going to have to do some manual therapy, mobilisation, whether it's the Maitland approach, the Mulligan approach, all of those have got really good validity for shoulder problems. I may need to do some massage of the tight muscles, which could be posterior cuff particularly, or even the subacromial space. And I may be doing some dry needling. All of these have some evidence, but particularly manual therapy and massage have great evidence to reduce pain, which will then improve the isometric strength as well, and then therefore will increase the speed of recovery. So that is my simple approach, and I found it highly effective, is firstly assess the shoulder, test the neck, because so many cervical spine problems are involved, then test the shoulder with isometrics first on day one, start exercising related to function, and I don't know if we'll get time for that given our time. I may be able to talk to you about after that when I do the live part of this talk. How do you progress from day one? But don't forget neurodynamics, and don't forget your manual therapy, because manual therapy has huge evidence for facilitating recovery in the short term. What you're not going to see, let me tell you the evidence treatments for acute shoulder problems, particularly cuff. Manual therapy, massage, exercise, rehabilitation. Some of them, there's equivocal, dry needling, acupuncture. When there is calcification, calcific tendinopathies, extracorporeal shockwave therapy. What has no evidence, zero evidence, so I'll put that in red, no evidence, is electrotherapy. Now, I know in India, you guys love your electro. I'm sorry to say, and I think it's good news, if you want to set up your own practice, you do not need a piece of equipment to treat shoulders other than TheraBand and some handheld weights. Ultrasound, interferential, shortwave, microwave, any others? I don't know. They're probably the main ones. Zero evidence for shoulder problems. Now that might irritate some people hearing this, but that's the evidence. I teach evidence-based practice at the university to medical students, and I cannot lie to them that there is evidence for electrotherapy for shoulder problems. There is zip, none, nada. Okay, so this is the approach. So I'm going to go through now, how do I examine the neck? Because I will check the neck on every shoulder that I see. And here's the thing, if what I'm looking for is an immediate hypoalgesic effect, if Jardin's neck is involved, or any patient you see his neck is involved, you pick the worst movement, you get the patient to show you a movement. We'll find out with Jardin, I'm pretty sure it's going to be this. So I'm going to get Jardin to go in a position that's his most provocative, the one that he talks about, because that's most meaningful for him. And I'll tell him, I want you to go to the onset of pain, P1. We measure that, he'll have that in his mind, I record it, and then I do a cervical test. And what I'm going to do is a test of cervical extension 3 times, and we're going to assess that range again. If the cervical spine is at least partly implicated with his shoulder problem, he'll get an immediate improvement in range of motion. And then that becomes the exercise. If it doesn't improve it, I move on from the neck quickly and go straight to the shoulder. If it's positive, that becomes home exercise. Even if it is positive, I will then look at the shoulder if I have time and start looking at isometrics. So you can already see I said I wanted Jardin to lead with 1, maybe 2 exercises. If time was an issue and cervical spine treatment led to an immediate improvement in his range of motion, that can be enough. On visit 1, that may be enough. If not, if I don't get much of a change, I'll then go into isometric testing, and then I'm looking to see which one, abduction, external rotation, flexion, gives him the most relief. I would start with abduction because, as I said, that is the one that I expect in about 70% of cases is going to be the one that gives him the most hypoalgesia and improvement in range. If it doesn't change, or if it's minor improvement, I then look at external rotation and then flexion and then internal rotation. So, and I won't have time to do upper limb tension test, and Judson, I'm sorry because of time, we probably won't be able to do palpation. So, but in a setting where I wasn't doing a lecture, I would definitely do these because I want to do some palpation, because patients want you to lay hands on. Patients want you to feel things. So in a real setting, a couple of exercises is great for you to go on, but I would do some hands-on because patients want it. They don't always need it. A lot of them will need it because the evidence is strong, but not all of them need it. But I will make sure that I've palpated them because they want to know that you have felt it. You feel the problem, you know what it is. It gives them confidence in you. So don't underestimate the power of palpation. And you must palpate the skin. I want to say that's so important. You must be able to visualize the area because you never know what you may see. I've seen once a pyrexic infection from a woman who was shaving her armpit and she got an infection in her axilla. Now that was missed by the doctor because he hadn't looked at her with just her bra on. Once I got her top off, she had a massive bulge in her axilla and she had a massive infected joint. Luckily it was drained and she recovered. So the first visit, you at least must see the skin that you're assessing in. Particularly because there are areas where the infections are more common. So, Jonathan, we're just going to have some, we're going to try and set this up. So there might be a bit of a break while we set up the room so we've got the right spot. I might get you out in here, Jonathan, where we are now to do some physical testing.
Sure.
Okay? Yep, thank you. Okay, Jonathan's coming in to show you and Jonathan's shoulder. And just so you know, This is a photo I took in Rishikesh. I love India, I love your country, so that was the photo I took in Rishikesh. Unfortunately, I can't be there live, which I would have loved to have done. You can see I love India a lot. Indian patient, Indian photos. I am in Australia, I promise. Jatin, can you show me again where the pain is?
So just about there.
Okay. So, like I said before, I want to see if your neck is involved or not. Okay. First thing I want to do is, can you show me that? You said it was when you're lifting your arm up. Can you show me what you do? Can you bring on that pain? And when it hurts, tell me.
Yeah. About there.
And where does it hurt? So that's your main pain?
Yeah.
Okay. So that's about, you can see is in mainly almost abduction, slight flexion, what we call scaption, in line with the scapular plane. And he's about 85 degrees. Okay, you don't have to hold it there, thank you. I want you to put in your mind's eye what that felt like. Now I'm going to do a test. What I'm going to do is test your neck, because you said you've had neck pain. I'm going to do a simple procedure which actually just stretches your neck. And then we're going to do that 3 times, and then I'm going to get you to do that again, and we're going to see if it's any different, for better or worse.
Yeah.
Can you just come across this a little bit, right? Thank you. Actually, I'll come around this way for the camera. Normally I'll do that side because I'm a very right-sided person. So what it is, it's a retraction exercise. Jatin, can you draw your head back as far as you can between your shoulders? Now I support his thoracic spine, and so I'm stabilising so he doesn't move his whole body, and then I give added overpressure to the cervical spine. And you can see my forearm is in the line of the force, and it's a pure horizontal force. I'm holding it for 10 seconds, and then we let it go. Is that okay?
Yeah.
No real big issue?
Yeah.
Really is, even if it is painful, tell them it's okay. With pain, with shoulders, it's just got to be tolerable. We'll go again. So stabilise the thoracic spine. I'm just talking loud because I forgot where it is. Draw your head back. So get them to do it actively, and then you add over pressure. And we hold it for 10 seconds. And relax. Okay. Now, for the sake of time, I would usually do it I'll do 3 times. We'll go one more time. Go again. Stabilise the thoracic, active, and then you add passive overpressure. Holding for 10 seconds. And now we're going to reassess. So Jatin, can you do that same movement that hurt you before? Tell me if it's any different or the same.
Yeah, it starts now.
Yeah.
It's lots of
isn't it?
higher. Yeah.
So it's already gone up about 20 degrees. This is really common. You'll see with shoulders. Thanks, yeah. So like I was saying before when I was just talking, when you were videoing, can you see how much that seemed to affect your shoulder? Yeah. So if I can give you that as a home exercise, how quickly you would respond. So as a home exercise, you can just do this. So at home, what I want you to do is get yourself in good posture, just like you are right now. Draw your head back between your shoulder blades. And you're doing it nicely because you're drawing it straight back. Then with your own hand, that's it. Come up a bit higher and push through your hand to draw it back further. And you hold that for 10 seconds, 3 times, and at least morning, afternoon, evening. Yeah. Could you imagine if you do that every day, if it already helped you once, if you do that every day, how much it's going to help? Yeah. And you can do that for pain relief. I'm saying 3 times a day, but if your shoulder starts really aching, just do that. Yeah. Okay. Okay. Yeah. You happy with that? Yeah. Now, a lot of patients, that's enough. And for time, that might be enough, and I'm aware of time now. I'm also going to do some isometrics. Now, they are, this is what I'm going to do. So I'll speak to Jatin now as a patient. Jatin, now that we already see your neck is almost definitely involved, but it doesn't mean your shoulder muscles, I still suspect your shoulder muscles are your problem, your tendons, which connect your muscles to your bone. So what I'm going to do is I'm going to do some tests. Now I'm going to start from the most common, and if that doesn't help, usually it does, but if it doesn't, let me know. Yeah. I'm going to get you to do some basic testing where you push against me and you match my resistance. So you're not moving. Okay. If it hurts, it's okay. Okay. So the pain has just got to be tolerable for them. I don't give them a score out of 10. I say, is it tolerable for you? That is a really important consideration. Again, if you want to ask questions after the video, you're welcome to. How we define that, because that's the new research. Rather than a score out of 10, it's what the patient can tolerate. Really important when you do your rehabilitation as well, that you consider telling them that the only reason you wouldn't exercise through pain is if they suffered the day after. If they get pain the day after, then you probably do need to give them an exercise that they can fall back on that's less strong. So let's have a look. Just have your arm just by your side. Yep. Now, no, I'm just going to do here. Now I want you to match my resistance. So it's a resisted isometric abduction. And push out against me. We're going to hold it for 10 seconds. And relax. Did that hurt at all?
A little bit, yeah.
Was that okay? Bearable?
Yeah.
So make sure it doesn't, I don't really get fussed on the pain because the research says it doesn't matter whether there is pain or not, it's whether how they respond the day after. One of the other key things that Jatin pointed out in the break was he thought I was saying hyper. I'm saying hypo, P-O, which means low level of pain. So just so you know, I'm looking for hypoanalgesia, not obviously hyperanalgesia, which means more pain. Okay, so we've done one. Push against me again. So just match me, don't beat me. And we hold that for 10 seconds, 3 times, so we've done it once. And relax. So if abduction gives an immediate improvement, I would stop. And that would be my home exercise. Day 1 is the cervical retractions and some isometric abduction. If it didn't help, we would then do external rotation. If that didn't help, I'd check flexion. If that didn't help, I'd look at internal rotation. In that order, because that's the order of likelihood. One more, Jatin. A bit closer to your side. Don't let them go out into abduction, you want it neutral. And relax. Now, Jatin, can you once more again do that position? Tell me when it starts to hurt. Look at that.
There.
That's even better.
Yeah.
So that's even better. So that's quite big improvement.
Yeah, definitely.
So that would be my exercise. So you saw the retractions of your neck helped?
Yeah.
3 lots of 10?
Yeah.
And I would write it down. I never leave with a patient without having it written down. Even if it's only just 2 exercises. And the other one is just doing what I just did then. At home, Jatin, all you have to do is have your arm like this, grab around the side of your elbow, and have your arm by your side.
Yeah.
Grab around the elbow and push against your hand. Hard enough that you can feel the muscles contract, but not moving it. And you hold it 10 seconds, 3 times. Okay, so do them together, like this one 3 times 10 seconds, that one 3 times 10 seconds, and 3 times, morning, afternoon, evening. But you can see you got improvements from that alone. If you do those every day yourself, how much better you'll be.
Yeah, absolutely.
Okay,
yeah,
cool.
Thank you for that, James.
Thanks, Jatin. Now, normally, actually, Jatin, might get Jatin to get the camera because for volume. Thanks. Normally, thank you, Jatin, for being not just a patient, but being a photographer.
Okay.
Normally, I would then go ahead and do these, but because of time, I've run out of time today, haven't got time. I'm happy to answer questions about this approach. And also happy to talk about, this is phase 1 of a very complex rehabilitation program. Usually over 3 months, I would be telling the clients most cuff problems, because they've built up over time and because there were a lot of ergonomic reasons and probably a lot of predisposing factors that are already there. It's about a 3-month program of graded exercise coupled with some manual therapy, exercise rehabilitation, very rarely that because there's not many calcific situations, and no electrotherapy. I hope this has been useful. In 40 minutes, it's very hard to give something that's even more depth than this, but this is a very simple overview. It's a very simple way of assessing rotator cuff shoulders problems, which are 2/3 of what you're going to see in your private practices or in your hospitals for shoulders. So thanks everyone. I'm looking forward to your questions.